Our presentation today is supported by the Health Resources and Human Services Administration of the U.S. Department of Health and Human Services. The information and content and conclusions are those of the author and not to be construed as the official position or policy of HRSA, HHS, or the U.S. government. Before we get started into the formal didactic portion of our presentation, I think it would be nice if we could all go ahead and take a moment to introduce ourselves. If you don't mind, please introduce yourself via the chat feature of our Zoom presentation today. Please go ahead and list your name, role, and location. Thank you. I'll go ahead and introduce myself now. I'm Dr. Sonia Sagel, and I'm a clinical professor in the Department of Medicine and the Division of Geriatric Medicine and Gerontology at UC Irvine. My clinical practice is in Orange and in Laguna Hills, California, and it's really my pleasure to be here with you today. Today's presenter is Dr. Manisha Pereira. She is an internist and board-certified geriatrician and an assistant clinical professor in the Department of Internal Medicine and the Division of Geriatric Medicine and Gerontology at UC Irvine. And her clinical practice site is at the Senior Health Center in Orange. And it's my pleasure today to welcome Dr. Pereira.
Thank you, Dr. Sagel, and welcome everyone to this didactic session on this very important topic on medical approaches to acute and chronic weight loss in older adults. I have no financial disclosures. So today's takeaway points, we have 3 takeaway points. So the first is weight loss has negative consequences, especially in our older adults. In a day and age where we are always focused on losing weight, it doesn't necessarily mean that lower the weight, the better your health. So we want to recognize the negative effects of unintentional weight loss. And especially in the elderly, there can be multiple factors that influence this weight loss. So we need to keep that in mind when we try to improve their weight and treat the ongoing weight loss. And again, treatment is also multimodal. Multiple disciplines needs to get involved when taking care of our seniors. Next slide. Our population is aging. By the year 2030, it's expected that 21% of our population will be over the age of 65. Right now, it's about 19%. And by the year 2060, 1 in 4 will be over the age of 65. This next graph depicts how our demographics will change by the year 2060. So we talk about the pyramidal setup of our demographic in relation to the age, but it's expected to change into a pillar because our senior population is increasing, whether it be because of baby boomers going into the age range over 65 or improvement of healthcare. Many factors can influence, but overall, our population is aging and we need to be prepared to take care of these senior patients. And when taking care of seniors, we need to keep in mind that it's not necessarily taking care of an older version of a middle-aged adult or a young adult. The physiology can change. And also, as you age, we tend to have more diseases, more related to organs like kidney disease, liver disease, heart disease. And with that, you're bound to be taking more medications. And medications have side effects that are known and unknown. And then medications can interact with with each other, some supplements you take. So we really need to keep this in mind. And because of these changes, the physiological changes that happen, diseases can also present very differently in our older patients. So we have to really keep an eye out for subtle changes that could happen. For example, a patient who has memory loss may not necessarily be able to express what's going on if they are in discomfort or if they're constipated, and it may present as agitation or irritation that we really need to keep an eye out for and pay attention to recognize this. And I mentioned dementia. These are unique challenges that occur in our seniors. So I, just need to keep that in mind, that our seniors need specialized care, and we as healthcare personnel and who are enrolled in taking care of seniors should have training, and we need to learn and advance our knowledge to be better equipped to take care of our seniors. Next slide. Let's talk about how nutrition changes as we get older. So our body composition can change. We unfortunately can have more fat than bone mass or muscle mass in our body. And with this change, there can be a change in our metabolic rate. So in general, the more muscle mass you have, the higher the metabolic rate. And with loss of muscle mass, the metabolic rate can decrease. And really, what a metabolic rate is, our bodies are constantly in need of energy. So when I'm talking, when I'm exercising or walking, I require more energy. But when I'm resting too, my body requires energy for various things, like I'm breathing, my heart is beating, and at a cellular level, cells are being repaired. So we really have an energy requirement even when we're at rest. But what happens is, as we get older, the rate of this energy requirement decreases. And our need for macronutrients and micronutrients. So macro is like protein, carbohydrates, fat, and micronutrients like vitamins and minerals can also change as we get older. And some of it is because of chronic diseases like kidney disease, liver disease. For example, when you have kidney disease, our bodies cannot produce vitamin D like a normal kidney would. So then we may need to think about supplementing the vitamin D. And fluid needs also change. As we age, our thirst mechanism, the sensation of thirst decreases. So even though your body needs more water, you may not necessarily get the signal that you need to drink. So I always encourage my patients to count how much they're drinking, pay attention to what their urine looks like, rather than depend on the thirst mechanism to stay hydrated. The other part to this is that our bodies become less efficient on preserving water. So you have a higher tendency to be dehydrated. And also medications, like if you're on a diuretic, which is a water pill that pushes water out, it can increase your risk of dehydration. So many changes happen in our body. And along with that, our nutritional requirements change as well. Moving on to weight loss, I want to actually talk about what's a healthy weight. So in general, we talk about the body mass index, or the BMI, which is a calculation taking into account your body weight and then your height. And there's a calculation that we can do to identify if your weight for your height is in a healthy range or not. So for people who are younger, a healthy body weight is about 18.5 to 29.4. But studies have found as we get older, this range actually moves up. So a higher BMI has actually shown to have lower mortality. And this range is about 27. Whereas a good BMI for a younger person is less than 25, but above 18. For an older patient, a good BMI is around 27. So this just highlights how older adults are, they have different requirements. Next slide. And as I mentioned before, when I talk about weight loss, I'm actually talking about the unintentional weight loss, because it really does give us a clue about what's going on with their health. And it requires an investigation to search for underlying health problems that usually triggers a weight loss in seniors. Before we identify what a significant weight loss is, we need to know how to define what a weight loss is and how to define a significant weight loss. So in general, on a day-to-day basis, about 3 to 4 pounds variation can occur due to water retention or water loss. So that could be a normal variation. But what about 10 pounds? Is 10 pounds a significant weight loss? My answer would be maybe, because there are other things that we need to look at. So really, a significant weight loss is defined by the percentage of body weight that's lost over what period of time. For example, 2% over 1 month, 5% over 3 months, and then 10% over 6 months or more. So that's a significant weight loss. So in general, for people who range around 200 pounds, so a 10% would be.
Okay, did you log on?
I'm going right now. I didn't realize that.
Maybe like somewhere between 10-20 pound weight loss. Next slide. And weight loss has negative consequences. When you lose weight, you lose muscle mass, so you can have a protein energy malnutrition, and along with that, you could have other nutritional deficiencies like micronutrients. This can lead to poor wound healing, and with loss of muscle, you can have poor mobility, poor balance, and you can lose your independence. It also increases your risk of infections, and when your mobility is low and when you're in bed and you have poor wound healing, you can get bed sores, and it can increase your overall mortality risk. But I wanted to highlight that it's not, all this can be interconnected. One can lead to the other and increase the chances of developing an infection or a bed sore because of the other factors. So how common is unintentional weight loss in our community? About 13% of community dwelling seniors can have unintentional weight loss. If you're hospitalized, this increases to about 25 to 50%. And in the nursing homes, more than 50% of the residents have unintentional weight loss. But it's important to remember, it's really not only about the location where the patient is. It doesn't mean that nursing homes provide poor nutrition to our seniors. We also need to think about what kind of seniors goes into nursing homes. They're usually the sickest of the sick who needs more help, more rehabilitation. So it really tells us that there's underlying diseases contributing to their weight loss. So looking into causes of unintentional weight loss, so about 50% of the time, it can be a chronic disease or diseases of the organ like kidney disease, heart failure, COPD, because you're constantly using your respiratory muscles because your work of breathing is more, infections, chronic infections, and degenerative diseases like Parkinson's disease, dementia, can cause weight loss. But I also want to mention even oral health, poor dentition can contribute to weight loss. Cancer or malignancy can be a contributing cause for weight loss. And I know, when there's significant weight loss, we always think about malignancy and we need to rule that out. But it's not the most common cause. 20% of the time, we don't actually find a reason. And this also includes the age-related loss of weight that we see in our patients. But of course, these patients need to be monitored, especially after an intervention plan, and reassessed as needed. 10% of the time, it's psychosocial. For example, especially during the pandemic, we saw a lot of social isolation in our seniors. They didn't have the means to go to the grocery store. Their appetite decreased because they were eating by themselves, and financial problems also can contribute. So think about psychosocial issues as well when you think about weight loss in someone. And here's a mnemonic to remember, and I hope you can all relate to this mnemonic. It's called Meals on Wheels. So always think about medications, especially if one of my patients have had weight loss. I always think if there was a new medication that was started, or is there a medication that could be contributing? And then depression, anxiety, emotions can affect your appetite, your intake, your motivation to eat. Alcohol does reduce your appetite, and it can cause nutritional deficiencies like vitamin B12, thiamine. And think about adult abuse. Is this a neglect of diet and nutrition? And I included late life events like bereavement, swallowing problems, oral problems, infections, hospitalizations. Wandering, I mentioned because of dementia, because if you have memory loss, you may forget to eat. So think about memory loss, and then metabolic changes, hormonal changes like hypothyroidism, high calcium levels, problems with your gastrointestinal tract, whether it's obstruction because of a tumor or like scar tissue, or whether you're not absorbing the nutrition. Even something that is simply, something simple like constipation can cause loss of appetite by causing more bloating. So it's something we can fix more easily. So think about constipation, eating problems, eating disorders, and dietary restrictions that reduces the appetite when they eat food, and then social isolation, as I mentioned before. But that it's a complicated presentation, especially when someone's older. So sometimes we do find one cause, like if you're hyperthyroid, you can lose weight and you can fix that. But most of the time, there are many other contributing factors in addition to your physical health, like function. Can someone go to the store, buy food, and cook food? Or are they just eating crackers and cheese most of the time? Socialization, are they socially isolated? Do they have memory problems? Are there medications? So I just wanted to highlight that there are multiple causes that can contribute, and it's important to identify them to improve their weight and the final outcome. Evaluation of weight loss always starts with a good history taking. So I think of it almost like detective work, where I would inquire about the weight loss, the period of time it happened, what are you eating? I always encourage to keep a food diary of how much they're eating, and when they're eating, do they have trouble chewing? And when they swallow, are they choking? Are they coughing? Does it feel like food gets stuck? And then what about your access to food? And then memory. Sometimes I have caregivers come in and prepare the food. They keep it in the fridge, hoping the patient will take it out and eat it, but it doesn't happen. So memory is also important. Medications and other symptoms that could suggest malignancy, depression, malabsorption, like having fever, night sweats, bleeding, with bowel movement. So things like that could be red flags that we need to look out for. And beyond that, depending on what we find, we can do blood work, we could do metabolic panels, we could check for anemia, thyroid problems, and always I make sure that I do an age-appropriate cancer screening. But if all this workup is not really pointing me to the right direction. I will also do CT scans of the lung and the stomach area to see if there's anything that we didn't pick up in our routine testing. And if we find something, we work on that, we treat that. But if we don't find the cause, we come up with a good plan to help improve the nutrition and their weight, but we reassess every 3 to 6 months. And I may repeat some of these tests as needed, depending on what condition the patient's in. So I mentioned the pattern of weight loss. So I just wanted to highlight 2 examples of some of the patients I've seen on how the pattern helped me find out the cause of weight loss. So this is patient A. She's a 90-year-old lady who has a diagnosis of dementia. She has poor vision, and she lives with her daughter, who is her primary caregiver. And they report that she eats well, but she keeps losing her appetite. So I think about all the factors that I mentioned: physical, mental health, social health, memory. In her situation, even though she has dementia, her daughter's very good about providing for her. So I had a good account of what she's eating. But of course, we have to think about mood. But in my interview with her, she told me that she's been having some stomach pain, but she does have a history of acid reflux and she takes medications for this. So with that in mind, I took a look at her weight, how her weight loss pattern has been, and you can see that there has been a gradual decline in her weight. So the initial workup didn't really reveal any abnormalities, any hormonal changes, electrolyte changes. But given her age and her presentation, I did do a CT scan to rule out any malignancies that wasn't presenting on the initial workup. And unfortunately, we did find a tumor. So even though she was eating, she was losing weight because of the tumor that we found, unfortunately. So this was one example of how weight loss can present in our older patients. The next one, patient B, she's a 76-year-old lady. She doesn't have any history of memory loss. She does have high blood pressure, diabetes. And she comes in with her daughter and reports that she's had weight loss in the past year. So this was a couple of months ago. So I just wanted to show the next slide. And you can see that there was an acute drop in her weight from the middle of last year to over like a 5-6 month period. And then since then, her weight has been stable. I put a question mark up there because, I'm not sure what happened there. It came down and went right back up. I think there might have been an error in checking her weight. It was December when that weight was put in. Maybe she was wearing a thick coat. So it's hard to explain that, but she did have a weight loss. When I talked to the patient, it turned out that during the end of last year, she had a lot of stress. She was worried about a family member and she was going back and forth taking care of this family member. And she did admit that she neglected to eat her 3 meals a day. But on further review, I also found that she was started on a medication for diabetes that could cause weight loss. So there were more than one factor to contribute to her weight loss. We decided, I did an initial workup to make sure there wasn't anything ongoing that we needed to treat urgently, but otherwise we came up with a good diet plan. We decided to hold off on the medication because, really when you're older, we do have room to have a little bit of a higher blood sugar level compared to someone who's younger until her weight picks back up. So that was our plan with patient B. So let's talk about medical management of a presentation of someone coming in with weight loss. So I wanted to say that prevention is always better than cure. It's easier not to fall into the hole rather than come back out. So always keep your antennas up, try to identify weight loss early, and so that everyone can intervene early. So when it comes to acute and chronic weight loss, I just wanted to give some examples of acute weight loss, what kind of situations can cause acute and what can cause chronic. So medication side effect, like the patient B, patient B, acute hospitalization, grief or stress or surgery can cause acute weight loss. And chronic is more of chronic diseases, infections, psychosocial factors, and dental problems. But it's really hard to separate saying these can cause acute and these factors can cause chronic, because there can be some overlap. So someone who's having psychosocial issues has surgery, you could have a weight loss because of both those reasons. Next slide. So when it comes to management, try to identify the cause and treat the cause if it's easily treatable, like thyroid disease, fixing dental problems, or medication that's causing side effects. And next slide. But it requires more intervention. And because of the multifactorial causes of weight loss in our seniors, like improving nutrition, we can think about medications to improve appetite and weight, and thinking about supplemental nutrition. How do we improve oral nutrition? So think about food preferences. It's, as I mentioned before, especially as you get older, because of the mortality and the morbidity involved, associated with unintentional weight loss, even a patient with diabetes, as long as their blood sugar is not very high, we can have room to increase our goals of blood sugar control. For example, if like a random sugar, if the goal is 140 in someone who's younger, I may raise that to about 150, 160 on someone who's older, because of the benefits and risks of losing weight over trying to control your blood sugar too tightly. Paying attention to cultural preferences when catering to these patients is also important. I want to say to avoid the therapeutic diets unless the clinical value is certain. I have had patients who self-diagnosed that they are gluten sensitive and stopped all gluten in their diet without a proper diagnosis and has had weight loss. So if you have concerns, talk to your doctor, and just make sure that this diet is right for you. Paying attention to color, texture, temperature also helps improve appetite. And you can improve the flavor by using different herbs and spices to improve, compensate for loss of smell and taste. And, you don't necessarily have to increase salt or add additional sugar. You can use herbs and spices instead. Increase socialization if possible. And then pay attention to food consistency. So if someone can have chopped food, it doesn't have to be pureed, so that they can enjoy chewing and enjoy the intake of food. And really, I also tell my patients, if you can't eat a significant portion of a meal because of many other reasons, you can do small but frequent meals to increase your calorie intake. Nutritional supplements. So it comes in many forms. It can come in the form of bars or liquid nutrition, mostly provides extra protein and calories. And, This shouldn't be a replacement of your regular food intake, but it could be a complementing supplementation. The supplements can complement your regular food intake, because we do have to think about micronutrients and vitamins, not only protein and calorie intake. The benefits of giving nutritional supplements in studies have been proven in patients over 75 years who are hospitalized, the greatest impact on mortality, on preventing death. But it really didn't improve their hospital stay or their functional improvement. But we can use supplements for a short period of time, especially if they're recovering from a surgery or if they need to, improve nutrition before a surgery. Next slide. So let's talk about medications. There are many medications that are out there, but we also have to think about some of the side effects when we think about medications. So mirtazapine is a medication we use for depression. It does improve appetite, but we need more studies to prove by how significantly it can improve appetite. So I usually can use this medication to improve, especially if there's an underlying mood-related disorder. But you need to keep in mind that it can cause sedation, it can cause electrolyte changes, so have to watch out for this. There are other medications like megestrol, which has proven to improve weight, but what it does is it improves the fat content. So doesn't necessarily improve your muscle mass, and it can lead to water retention, heart failure, and blood clots in your veins. So can be life-threatening, some of these side effects. So really you have to use it with caution. Cyproheptadine is like a Benadryl-like medication, so it can cause confusion, and the effect on appetite and weight gain is, it's not very high, so I don't generally use this drug. Dronabinol is a cannabinoid-like medication, again, can cause drowsiness and dysphoria. And really in our seniors, it is a big issue having drowsiness, because they can fall, they can have a fracture, and wound healing can be impaired if they're already having weight loss. And there are options of using growth hormones. Again, you have to be cautious because it can increase your blood sugar, cause water retention, and it should not be used in patients who have cancer. Next slide. So overall, take-home points for medications: short trial, need to watch out for side effects. If there's no improvement, I would stop it right away. So just a little about tube feeding and artificial intravenous feeding. So tube feeding, it's not recommended for chronic use. It has its own side effects. It can cause aspiration pneumonia. It can cause infections of the skin around where the tube was placed. It can cause electrolyte changes. We use tube feeding for before and after surgery to improve nutrition and healing in patients, but it's really not recommended for patients with dementia, end-stage cancer, or COPD, because we haven't really seen an improvement in outcome, and considering the possible complications that come with it, it's not recommended. And it has been found that life expectancy after tube placement is about 1 year. And it's hard to say whether this is because of the tube placement itself versus the actual, the conditions that really required the patient to have a tube placed in the first place. And total parenteral nutrition, which is the IV nutrition, again, we use it if patients are unable to use their gut for nutrition, especially in a hospital setting, but it does increase the risk of infections, even fungal infections we have seen in patients when they're on it for a long time. So I just want to say this is a multidisciplinary action plan. It requires multiple steps like gathering data, coming up with a good treatment plan, implementing, reassessing the plan, and you revise it and you kind of change it as the need arises. So it's a dynamic process, taking care of someone who's had weight loss. And that's it from me. Thank you.
Thank you, Dr. Pereira. Thank you so very much for that presentation. Does anyone have any questions for Dr. Pereira? Please unmute yourself or any comments. Any comments or questions for Dr. Pereira?
Well, this is Daryl. The one thing that really strikes me in one of the interventions is the food preferences. And of course, those that is often difficult with Meals on Wheels clients, because we want them to be on a specific kind of diet that meets the nutritional requirements.
Mm-hmm.
So how do you sort of monitor that and assess when you can actually make a case for they need to have something that they like rather than something that it's required that they have?
As in, like if they prefer beef or like a red meat.
Yeah, well,
Yeah.
for instance, if they won't eat anything or they don't like to eat anything with reduced sodium, let's say.
Oh.
But the nutritional requirements are that there be low sodium in senior meals. So that's sort of what I was,
Okay.
those kinds of things.
Yeah. You know, we could use different herbs and, you know, spices to have to change the flavor. You could do, you know, it depends on the meal, but lime juice, something to flavor the food, but not necessarily increase the salt intake. Yeah, and then the consistency, right? Kind of paying attention to making sure that the food is the temperature, and maybe they can reheat it if they, you know, if that improves their appetite. Kind of thinking about other ways to improve and not necessarily increase that salt intake, which can be more harmful.
Right.
Yeah, and then socialization. So, I mean, especially if you're in a nursing home, I know it's been difficult with the pandemic, but, you know, if they can eat with somebody else, have conversation, it can increase their appetite and intake.
Thank you.
May I just add a few, sorry, may I just add a few comments to that, Daryl, to your question? Sometimes it's very challenging. You know, a physician or provider might indicate on a questionnaire or something that their patient should have a low sodium diet, or and they don't really think about what that means in the context of an older adult. And if the person is particularly frail, you know, we're worried about weight loss. We do look at the risk benefit, right? So there's a lot of benefit to reducing sodium content in the diet. And there's actually some national information about how we could improve longevity in our country overall if we simply just reduce sodium content in food. But I had a patient, actually, he was a very elderly gentleman. He was probably 96 years old. He was an elderly Asian male, and he had congestive heart failure, was on a low sodium diet from his heart doctor, and he just stopped eating. And the family was presenting him with anything and everything that they possibly could, but nothing was palatable to him. He wanted to eat a particular kind of soup with noodles in which the broth was just extraordinarily salty. And, you know, we had a conversation about goals of care and life preference, you know, and sometimes we do have to, even though we know that a reduced sodium diet may negatively impact someone's chronic condition, sometimes we just make the allowance and raise the threshold. Yeah, sometimes.
I also wanted to mention, this is Debbie Case, that when you talked about portions, Doctor, you know, you kind of glossed over it, but that's really important. Seniors have a tendency to graze. And when you present them with a full plate of food, it sometimes turns them off. And so the food goes to waste. They throw it out after they've eaten only a third of it. That's why I like our what we call our cold meals, when there's a lot of different, I call it happy meals. There's a lot of different elements in it that over a period of time, they could eat and snack on the different elements, and then they're getting their full breadth of nutrition, but it's over the afternoon. You know, it starts with lunch and then they have the fruit a little bit later, or the nuts a little bit after that. So I think that's real important to Meals on Wheels programs too. Is the portions and having them able to graze through the day.
That's right. Yeah, I do. Yeah. People do tell me that they save a portion and have it later on.
Well, thank you, Debbie.